No, thanks very much, Anna, and thanks everybody. Really great to be here in person. I'm so glad I'm not in my bedroom doing this online. So yeah, a pleasure to come and speak to you today about an Applied Partnership Award, which is due to finish up. I'd actually hoped to be here with my knowledge user principal investigator, Marie O'Brien, who's from the HSE, but unfortunately Maria's unwell, so she hasn't been able to join us today. But we've prepared this presentation together. I'm going to tell you a little bit about the project, and I'm going to end up with reflections from an academic principal investigator and knowledge user principal investigator, which I think is going to fit really nicely with the other presentations in this session. So I think we're all aware as health researchers, and Jonathan has just outlined the 17-year time lag from evidence to practice. And this is something I think as health researchers, you know, if anything's keeping you awake at night, this is potentially one of them in terms of many of us are long in the tooth at this game. And really, if we're to be honest and think about, you know, sometimes our families say, so, you know, what have you found? What difference has your research made? And, you know, that can be a worrying question sometimes, I think, for health researchers. So we know that healthcare, some of it is evidence-based some of the time, but we're all very aware, I think, of the challenges in this space as well. And this is the classic evidence to practice gap that we try and grapple with within implementation science. And I think the project that I'm presenting today, I think is probably the best that I've been involved in terms of attempting to bridge this gap. So the Making MECC Work project evolved as part of a HRB KEDS award called Interact for Health, which I got building on my HRB Research Leaders Award. And the aim of this project, Interact for Health, was to work with our knowledge user key partners who were the HSE Health and Wellbeing Division. So we worked with them, with my research group, the Health Behaviour Change Research Group, to try and develop a shared research agenda. So we were facilitated in this process by a knowledge broker, Professor Maureen Dobbins from Canada, who worked with the two groups, the HSE Health and Wellbeing and ours, an academic research group, to try and identify what were our strengths, what could we bring to a HSE group, and what were their key questions that they wanted to address. So one of the outcomes of this project was that myself and Marie O'Brien, developed an Applied Partnership Award in which we sought to do a project which would optimise or improve the implementation of a national programme called the Making Every Contact Count programme. So our aim was to address what they were seeing within health and well-being as a really pressing problem around poor implementation of the national programme at the outset, and then bring our skills as an academic research group to that. So by way of background, we're probably all familiar with the importance of health behaviour in terms of improving health and well-being outcomes and in terms of reducing chronic illness. There's evidence that the delivery of brief behaviour change interventions by healthcare professionals within healthcare can be an effective strategy in terms of improving health-related behaviour and improving outcomes. And international guidance, such as NICE guidance, recommend that all healthcare professionals should be trained in skills around delivering brief behaviour change interventions. So as a result of these types of guidance, we're actually in a very fortunate position in Ireland in that we have actually maybe unique internationally in that we have a standardised national programme for training health and social care professionals called MECC. We know that there were challenges in terms of implementation of this programme, and we know from international evidence that these types of programmes can be quite challenging in terms of getting buy-in from staff, ensuring that they're delivered and that there's uptake across different types of health services. However, in an Irish context, evidence was lacking around. We didn't know what the main barriers and facilitators were to implementations. This was the aim of the Making MECC Work project. So our project had 3 work packages. We started off with a survey study with healthcare professionals, getting their views about barriers and enablers to implementation and delivery of MECC interventions. We followed up with a qualitative survey or a qualitative interview study in which we tried to get more in-depth information about barriers and facilitators. And we brought together then the findings from these first 2 pieces of work into a consensus study to develop recommendations. And we hooked all of this work onto theoretical frameworks of the behaviour change wheel and the theoretical domains framework. So in study 1 then, we had 357 healthcare professionals who participated in the survey from a range of different disciplines. And what we found was there was scope to improve levels of delivery of MECC interventions. So where these were all healthcare professionals who had attended the MECC training, but there was still room for improvement in terms of increasing levels of delivery of MECC interventions. When we asked about barriers and enablers, we found that enablers included things like having a supportive environment, beliefs in your own capabilities, whether there was a perception about a good fit with your own discipline or your professional training, where people identified as having high levels of skill, that they set intentions and goals, and they had a strong belief in the importance of interventions such as MECC. Barriers then included things like negative emotions, healthcare professionals reporting feeling stressed, feeling that they thought delivering MECC interventions caused conflict within their relationships with their patients. Barriers to prioritization, very often workload, challenging demands, and a lack of support across their work environment. So in the qualitative study then we interviewed 37 HSE staff members, and they told us really throughout these interviews, respondents really highlighted the importance and the salience of the environmental context in which healthcare professionals were working. So whether they were facilitated, so that's facilitated practically, such as having space within their health services, or facilitated at a more social level in terms of whether senior management also endorsed the use of the programme. These were very important in terms of enabling delivery. So we brought the findings of these 2 studies together for our final consensus study, which was a 2-phase study. First of all, online, where we had 23 key stakeholders who brainstormed on free text-generated strategies which they thought would overcome some of the barriers and address and harness some of the enablers identified in studies 1 and 2. We then brought a subset of this group together for a 2-day consensus workshop. So these would have been people, senior HSE people in practice in policy, people involved in MECC delivery, and representatives from patient and public involvement groups. And we worked together through a process of rating, ranking, to identify 9 top strategies. So you can see maybe some usual suspects here in the pictures from the consensus workshop. And from this work, we have produced a policy brief in which, among other things, we've highlighted and given a little bit more detail about our 9 recommendations. So we've put these together in an executive summary in which we've identified and differentiated between systems level recommendations. So for example, number 1 there is about providing staff with dedicated time. So in terms of looking at addressing that recommendation, that really has to be at a high level HSE systems level. Versus more organization level recommendations, which are things like developing a service directory for healthcare professionals to refer people onto after MECC interventions. So we're really in the process now of a number of dissemination activities to the HSE MECC implementation group. We've presented the research and discussed the research and the recommendations to some relatively senior HSE groups, including the HSE Executive Management Team. We've had a number of public dissemination events. So, in conclusion from this research, I think very often as health researchers, this is sometimes what our day-to-day looks like, and certainly during the pandemic, I think we could probably all relate a little bit to the feeling captured in this photo. But I think this type of research really highlights that we cannot be effective if we're operating in this way. So from my own reflections as an academic PI, I think it was clear that the relationships and communications were really key. And there was an interesting question there earlier, I think from you, Grace, about the pandemic and the different recommendations about online versus in-person. So this work was going on largely within the pandemic. So we were starting relationships and networks fully online, and it was very, very challenging. Whereas when we brought people together for the 2-day in-person workshop, it just transformed people's interest, willingness, and buy-in. Partnership from the outset was really, really critical. The fact that I had worked and our group had worked with the HSE group before we ever started this project was critical. So basically from the academic perspective, this gives us interesting and important questions. But from the HSE perspective, this means that there's buy-in from the outset, that they feel that this is their project. They care about whether the research actually happens, and they actually care about the results, which sounds like setting your standard, your bar really low, but I think you can relate to what I'm saying. There was certainly a clear pathway for dissemination and implementation. I mean, the HSE actually were really keen to hear what we found. They really want to see the papers. They want to get the policy brief. There's already been some talk, I think maybe Gary mentioned as well, the challenge associated with other perspectives. And certainly I think as academics, we're often in a very privileged position that we get to speak to lots of people like us. And I think this type of research really puts you outside of that box, and I think that that's what's needed. For me, this project also highlighted that the lines between research policy and practice are really fuzzy. And there's this whole thing of, the HSE want a dissemination activity, but who's going to do it? I mean, I'm teaching on a master's program, I'm whatever, maybe I'm not available. So I think we all have to, as health researchers, show some flexibility, go beyond what we kind of usually do. But I think also we can't do it all. So it's about harnessing resources from our institutions, getting other people with expertise where we can. I think also research and healthcare infrastructures are really needed, and I think what Isabel was talking about in her presentation around, when a project is finished funded, the funding dries up, there's still dissemination activities to happen to really ensure impact, and that can be very challenging. So these were Maria's reflections from a knowledge user PI. So she also talked about the value of having an established relationship, so that the networks here were key from the outset. She talked from a HSE perspective about there's a real value in collaborating with academic PIs because they really think, oh, well, they have expertise. So, a knowledge depth that they feel they just wouldn't have access to otherwise. There's a real value, and certainly when I've been presenting these findings to HSE, they're really delighted to see Irish research, so research that has taken place within their health services that can actually be applied. I was really interested that Maria reflected, and I've spoken to others as well, who reflected that the Applied Partnership Award was perceived as being really good value for money for the HSE. So they say, if they went out to a market research company, this research would not be done as well, and it would be much more expensive. So I thought that was an interesting perspective as well. For Maria, it has enabled international networks for the Irish MECC programme. So they're now linked into groups within the UK, groups in Scandinavia, who we've been able to link in through the research. And the research has really raised the profile of the national MECC programme. And at a personal level, Maria also says that for her, it has added to her satisfaction of her job that she's involved in this work. So I want to finish by thanking all of our research team within the Making MECC Work project, and in particular I'd like to highlight Una Mead, Dr. Una Mead's work, who was the postdoctoral researcher, and Una led out on a number of these studies. So thanks very much.